people with CLL can now live out really relatively normal lifespans. And this is fabulous, but it also comes at a cost. And we need to start at the beginning, specifically studying how patients respond to vaccines or other immunologic processes.
That's Dr. Gwen Nichols, the Chief Medical Officer for the Leukemia and Lymphoma Society. She'll be back later in the show. Today on Cancer Buzz, understanding COVID-19 vaccine efficacy in patients with chronic lymphocytic leukemia. What you need to know is next. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Patients with chronic lymphocytic leukemia, or CLL, have had the unique challenge of living with a heterogeneous disease and compromised immunity during a pandemic. Oncology professionals adapted to treat these patients with the highest care possible during an unpredictable time, and they continue to work for solutions to support them as the Delta variant spreads through the country. That spread, along with spikes in infection rates and the FDA's approval of a booster shot for certain immunocompromised people, underscores the need for more and better information on COVID-19 and vaccine efficacy. Cancer Buzz wanted to know how critical a patient registry is to understanding blood cancers in the context of COVID-19. Dr. Nichols pondered this question in our conversation.
Last year's American Society of Hematology meeting, which was virtual, we got to see a really large number of studies from around the country that basically told us that blood cancer patients, as compared to age-matched controls, had a much higher risk of morbidity and mortality should they get COVID-19. And we had certainly been hearing that from our patients, but it was stark when we saw all the different reports from around the country and, in fact, around the world. And so what came to us was that the vaccines were about to be rolled out and no cancer patients were included in any of the vaccine trials. So not only did we not understand the safety, but we didn't understand whether they would be efficacious in cancer patients. And there were not plans. We convened investigators in the blood cancer space from around the world to say, is anyone doing studies of the vaccine? And while there were some small studies at the NIH that were planned, there were no big studies. So we provided some financial support for some well-conducted, clinical studies, but we knew that was going to take 6 to 9 months to get done at an academic medical center, and even longer from the National Cancer Institute. And we had a registry that we had been beta testing, and we opted to use that. It seemed like the perfect opportunity to have patients participate in answering these questions for us. As they were about to get vaccinated, we could find out with patient-reported outcomes how well the vaccine was working and whether it was safe for patients.
How many patients do you have participating so far?
We had set this up for about 1,000 patients. That's what we thought. We launched it in February, the end of February, with a company called Citizen, and that's Citizen with 2 I's, to be our, technology company for this effort. We told them about 1,000 patients, and within the month, we had that 1,000 patients. And in fact, now we have almost 10,000 patients who are part of this registry. And this is, informed consent. It has an NCT number. This is a bona fide clinical trial, but it is one of patient-reported outcomes. And about 3,500 of those patients have gotten serology done. So antibody testing on both the spike protein indicating response to the vaccination, as well as nucleocapsid to find out who had in fact been exposed to the virus itself. So we've gotten a huge amount of information from these patients. Eventually, we'll have their electronic health records as well because the patients consent to the use of their EHRs. But right now, we have patient-reported outcome data related to safety, what medications they're taking, and so forth, so that we really could have a look both at the safety profile, which we published on our website, so that patients and providers could refer to it and tell patients, yes, thousands of people like you have gotten the vaccine safely. And also efficacy of the vaccine and who does and doesn't make an antibody response.
And how did you reach those 10,000 patients? Can you describe for us what that provider education and communication looks like?
We have a really 360 approach to helping patients, and I see the Leukemia and Lymphoma Society, or LLS, as a physician extender. We have both print and electronic materials for all of the blood cancers, getting down into subtypes of lymphomas, myeloma. We have very basic information about how to understand your blood counts, what to ask your doctor. We have also an 800 number, which is manned during the daylight hours by social workers and health educators who can help patients find financial assistance, resources for support groups, for one-on-one, we call it first connection, connecting with another person who has your disease, and copay assistance, which many patients need to be able to afford their medications.
I'd like to shift now to your antibody research study. Have you been able to publish the first findings yet? And then how will those findings help patients and their health providers?
Well, we actually published the initial almost 1,400 patients who had pre and then post-vaccine serology done. And by post-vaccine, I mean 2 weeks after their second mRNA vaccine. We had very few blood cancer patients who received the single adenoviral vaccine. So we looked at patients who were, by the CDC criteria, fully vaccinated and had serology done. And that information was just published in Cancer Cell this past month. So I believe that both the safety information, and the safety is on over 4,000 patients, the safety really mirrors that found in the healthy population. There are no new early safety findings, though we'll continue to follow for long-term safety. We didn't see anything out of the ordinary in the blood cancer patient population. Everyone had the same things that many of us had: sore arms, achiness, some fever. We did notice one thing for safety, and that is lymph node enlargement, which, of course, in the blood cancer population can be very concerning. But this was fleeting. It was tender lymphadenopathy, and it went away within 10 days. So it was actually a good sign of reaction to the vaccine and not reactivation of cancer, which was something many of our patients cared about. In terms of the antibody study, what we published in Cancer Cell was that a full 25% of blood cancer patients do not make any antibody after full vaccination using either of the mRNA vaccines, so that they may still be at significant risk for breakthrough infection.
There's been a lot of news coverage about the immunocompromised population and the vaccines, and therefore a lot of uncertainty. What have you been advising patients who are immunocompromised to consider with the vaccine, the booster, and evolving social distancing guidelines?
Well, I think it's really important also for both patients and their healthcare providers to help advise patients that just because you're vaccinated doesn't mean especially in the blood cancer, in the immunosuppressed population, that you are fully protected. And so we are advising patients to get vaccinated, but act unvaccinated. And this is particularly relevant for people who have B-cell malignancies, because both the disease itself as well as the treatments seem to be responsible for the lack of ability to make antibody. So there are two caveats to this. One of them is, and I'm sure your listeners know, that antibodies are not the only way our immune system fights viruses. And so we are looking at T-cell responses. So I'm hoping in the coming months that we'll be able to look at whether people have alternative immunity when their B cells aren't functioning.
What should our listeners who treat this patient population be considering right now?
The second piece of information that I think is really important for your listeners is what this implies for anyone who is getting a B lymphocyte suppressive agent. And I say this particularly about anti-CD20 therapies because physicians don't just use this in the instance of B-cell malignancies. These antibody therapies, monoclonal antibody therapies, have been incredibly impactful for patients with a variety of immune disorders and are used in rheumatologic diseases and in neurologic diseases. And so there may be people outside of the blood cancer space who are also at risk because they're taking anti-CD20 therapy for not having a full antibody response after vaccination.
That's important information. So, of course, in mid-August, the FDA cleared boosters for people with weakened immune systems like this patient population. And then they approved the booster for 8 months after the last dose for the general population. What does this booster mean for these patients? Up until now, have you been receiving a lot of inquiries into LLS?
We're incredibly happy about this. And in fact, we lobbied the CDC, and one of my scientists, Dr. Larry Saltzman, who works for LLS and is also a CLL patient, testified at the ACIP meeting to the CDC about the importance of considering boosters for the immunosuppressed blood cancer population. So we were thrilled when they unanimously voted for this to happen and it went through the proper channels. We also know that there were patients, including patients in our registry, who went out and got a third vaccination before it was approved. They knew they were seronegative, they weren't making antibody, and they were desperate. And many of them found ways to get a third vaccine. And so we are in the process of analyzing the data for patients who told us, I'm getting a booster, can I get a blood test? And our informed consent allowed for that. And so we sent them blood test slips and they went to LabCorp. Right now we have about 29 or 30 patients who, while we weren't approving of it in any way, and neither were physicians at this point, patients took it upon themselves and went out and got these vaccines. And for some patients, it does seem to be effective. Some people who were seronegative just needed that extra boost to be able to get over the top. So I'm very happy about the boosters. Dr. Saltzman, who I mentioned, is manning this study. He's the PI of the study. And they had, since the approval, 1,500 emails from patients. So we're really hearing from patients that they want to know if they were seronegative before, if the booster is effective for them, and whether it's safe. And we do believe it will be safe, but we don't know yet for whom it will be effective. And so we really want to study this in a scientific fashion so that, number one, we don't waste vaccine if it isn't going to be helpful. And number two, that we can encourage patients, yes, get it. It's the right thing for you. And so we are in the process of amending our consent form so that we can study specifically people who are getting boosters through our registry.
Last question, Dr. Nichols. What's the biggest takeaway from the pandemic that cancer care professionals can use to treat their patients now and then moving forward?
I think the big lesson is when we have a plan for vaccination, for any kind of treatment of large numbers of people, our immunosuppression is really good at treating these malignancies. You know, people with CLL can now live out really relatively normal lifespans, and this is fabulous, but it also comes at a cost. And we need to start at the beginning, specifically studying how patients respond to vaccines or other immunologic processes, because it isn't going to be the same. And we need to figure out early on how to protect patients. And I think we've made some great collaborative efforts with the UK, with Israel, with our colleagues who do transplant biology. And I hope that that continues afterwards so that we won't be caught as we were now scrambling to get these answers for patients.
You can find more resources about the LLS National Patient Registry and the LLS COVID-19 Antibody Research Study through the links in the show notes. We know your time is valuable, and we want to thank you for supporting Cancer Buzz. If you're enjoying this audio show, you might want to check out the Cancer Buzz TV channel. There we go deeper into current topics in cancer care delivery. Just search for Cancer Buzz TV on Apple Podcasts. We'll be back next week for a discussion with Dr. Deborah Patt, the keynote speaker for the 38th Annual ACCC National Oncology Conference. She'll be speaking on cancer care's road to recovery from COVID-19. You won't want to miss that one. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.